Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome, everyone. Welcome to another episode of Christine and Jeff Primary Care Conversations. Hello, Christine. It's been a few months. How are you?
It has been a few months, but thankfully it is almost spring here. So we're going to spring forward with a huge lineup of wonderful sessions and spectacular guests.
I can't wait. And today I've been looking forward to this episode for some time. We are joined by the great Dr. Arya Sharma, honestly referred to as the father of modern obesity medicine in Canada. He's really helped move obesity out of the world of blame and willpower and eat less, move more into the modern chronic disease framework. Like, he's taught us all. He founded Obesity Canada. He shaped the Edmonton obesity staging system. And we have him here for a few minutes. So we're so exciting. We're going to not talk about another GLP-1 algorithm because you guys have all heard that 1,000 times. We really want something more personal and more interesting. We want to find out how Dr. Sharma found his way into obesity medicine, how he saw what others were missing, what surprised him along the way, and where are we going to be 10 years from now in treating our patients with obesity. So, Arya, welcome. We are just so excited.
Yeah. Hi, Jeff. Hi, Christine. It's good to be with you. I'm sitting here in Germany at my desk, looking out to the window. It's a wonderful 27 degrees outside. Sun is shining. I guess that's a lot better than you have in Toronto, right?
A lot better.
So, yeah, you've said it. It's been a long journey. And, some of your listeners might not know this. I started out my medical career as a nephrologist. I did my medical training in Germany. I did my training in general internal medicine. Then I went on into the subspecialty nephrology. And as a nephrologist, I was doing all the nephrology stuff, looking after patients on, chronic acute hemodialysis. We had a large transplant program. I kind of got interested in the whole issue of hypertension. And I did a lot of research on hypertension. And it was sort of in the early 90s that, I became interested in the question of, why is it that blood pressure goes up when you gain weight? There wasn't really a lot of mechanistic stuff. There was quite a bit of phenomenology. So we knew that when you gain weight, people, cardiac output increases, people get volume expanded, blood pressure goes up, but it wasn't really clear what was driving all of that. And, as a nephrologist, the minute I heard volume expansion, sodium retention, I became interested. That was kind of my area of research. And, this was the early 90s, and it wasn't until 93 that leptin was discovered. And leptin was really the clue to the whole thing, because it turned out that leptin, not only the exciting discovery that now suddenly adipose tissue became an endocrine organ because it was secreting not just leptin, but a whole bunch of other things. But it turns out that leptin, apart from its effect on appetite, has a whole bunch of other things that it does. And one of them is to increase sympathetic nerve activity. And so when you have elevated leptin, then your sympathetic activity goes up, and that, of course, activates the renin-angiotensin system, and then you end up with sodium retention. And so I think it's pretty fair to say that hypertension in people with obesity is probably the most common secondary form of hypertension. When people lose weight, their leptin levels fall, and their blood pressure goes back to normal. So, that was the mechanism. And so as I was working on this, I went to my first ever obesity meeting. And this was a meeting in Germany. This was the German Society of Obesity, I believe. And I went there, and there might have been, 50 or 60 people in the room. And I looked around the room, and as far as I could tell, I was the only physician in the room. Everybody else, there was dietitians, there was exercise people, there was a bunch of psychologists, there was a couple of guys, basic stuff, a lot of health promotion, prevention, policy type people. But really, there were no clinicians. There were no medical doctors. And I, coming from hypertension and having done all of the research and clinical trials and, with the ARBs that came out in the 80s and 90s, I looked around and I said, what, if this is ever going to be a disease, we have to think of it as a disease. And we have to, base our therapeutic approaches on the actual science. And it was pretty clear at the time to me that, telling people to eat less and move more in obesity is probably as effective as telling people with depression to cheer up. You know, if you don't go after the actual science, and even if you assume, or even if you say that, ingestive behavior is the root cause of the problem, well, ingestive behavior is a very complex behavior, and there's a lot of biology in behavior. And so, and as the science evolved, my thinking on this became much clearer. And I said, if you're ever going to find a treatment for obesity, it's got to be based on, what actually happens in the brain. It was pretty clear to me that body weight is controlled in the brain, appetite is controlled in the brain, energy balance is controlled in the brain. Well, then brain becomes the target of intervention, right?
But you had no drugs. There were no drugs back then.
There were drugs. There's always been, there've been drugs for the last 50, 60 years. They weren't great drugs. Now in the US, they've had fentanyl for the last, I don't know, it's almost like 100 years, and it still probably is the most widely used obesity medication. We never had it in Canada, but that was around. And then we had sibutramine. People might remember it was called Meridia or Vidactil. I had a lot of patients on that, and they did great. In fact, I was on the steering committee of the SCOUT trial, and the SCOUT trial, contrary to what most people believe, actually showed how safe this medication is, because you give this medication to people who shouldn't be taking it, and you still don't kill anybody. So, how safe do you want to be? But the company that had Meridia at the time wasn't very enthusiastic about it. There was a couple of, class action suits going on. And so despite the fact that the FDA said, well, it's fine by us, the company decided to withdraw it anyway. So that was there. And then we had Rimonabant came along. That was the CB1, agonist. And that also wasn't that bad a drug, but I think there was a couple of problems in how the company positioned the medication. And, here you have a centrally active drug that goes after the cannabinoid system. And they really hadn't done the studies to see what this does to mood and depression and anxiety and all that stuff. So when they launched the medication and, problems started, which, were easy to foresee, they didn't really have a good strategy on how to mitigate that. And so they ended up going off the market. So it wasn't that we didn't have obesity drug, we just didn't have, great obesity drugs. Well, all of that changed the minute we had liraglutide. When liraglutide came to market, that was the first time in our clinical practice. And I can tell you in Edmonton, we had a pretty big surgical program. And I had this one patient on liraglutide, and it wasn't even much. I think it might have been 1.8 milligrams or something. And she was actually, a candidate for bariatric surgery. And she ended up losing, I think, almost 20 kilos on this medication, to the point that the surgeon no longer wanted to operate on her. And this was the first time that's ever happened that a surgeon tells me, they don't want to operate. That was a breakthrough. And then after that, we had semaglutide, and then now we have other stuff coming along. And so everything has changed, right? Now we think of obesity, as something that requires medical treatment. Not to say that the lifestyle component, is not important, but, that's always important. When we talk about hypertension, we want our patients to eat less salt. We want them to be more active. We want them to do, mindfulness and all that stuff. When you have people with elevated cholesterol, you also want them to, change their diets. Patients with diabetes need to change their diet, right? So it's not that the diet and exercise is somehow special and only people with obesity need to be doing it. Everybody needs to be doing it, right? But if that's all you have for obesity, well, then you ain't got much.
So what do you, now there's been such a transition though from weight to health. So we have these great drugs in our toolbox, and we're now talking, we've moved beyond the scale, right? What do you think?
Yeah, absolutely. The scale was never the issue. Part of why we had to come up with the Edmonton obesity staging system was because I realized very early on that size does not reflect health. You can have two people, they've got the exact same BMI. One of them has sleep apnea and pre-diabetes and fatty liver and, knees are hurting and all of that. And the next guy, exact same BMI, maybe exact same body composition, and has none of those problems, right? So basing decisions on, BMI tells you how big someone is because it's a measure of size, essentially. You could be telling me your clothing size, and there's as much information in that as there would be in your BMI. It simply does not tell me how sick you are. And this has now been widely recognized. So when we look at the latest recommendations from the European Association for the Study of Obesity, so the European algorithm, or even, the Lancet Commission paper, with which there's parts of that I disagree with, but they've also made the point that obesity now is a clinical diagnosis, right? I mean, you can use BMI or waist circumference or waist to height ratio or maybe even body composition as a screening tool. But ultimately, if you want to make a decision, does this patient actually, need treatment for obesity or is at risk from their obesity? You've got to see the patient. I mean, you can't be looking up on charts and stuff. I mean, you got to actually see the patient, take a history, do the lab work, maybe do a bit of imaging. And then you decide, okay, yeah, this is somebody who probably is going to benefit from obesity management. And that by definition then makes this a patient with obesity, right? So that's a big change, right? I mean, we've gone from numbers on the scale or numbers on the chart to actually making this a clinical diagnosis, which means I have to actually see my patient, examine my patient, take a history, do all of that stuff before I can actually make the diagnosis.
And what marked the change in the messaging? So you certainly said there was a change in the therapeutics that dramatically pushed, options forward and treatment forward. But the messaging is so integral, right? And you described this small, intimate group in Germany. You were the only physician. Now obesity education, obesity treatment expands all areas of medicine, primary care, endocrinology, sleep medicine. What do you think marked that change?
Well, Christine, you're so right. I mean, one of the exciting things, at my point in the career, I get invited to speak at a lot of meetings. And so I go to, obviously I go to diabetes meetings, I go to cardiology meetings, I go to lipid meetings. I'm just on my way to a hypertension meeting next week. I've been to oncology meetings, I've been to rheumatology meetings, I've been to orthopedic surgeons have invited me. I've been to dermatology meetings. So, and in fact, having to go to all of these meetings or getting invited to all of these meetings just shows that there is no area of medicine that does not have a stake in obesity, because, I mean, you'd have to be practicing a medicine below a rock to not have, 20, 30, 40% of your patients presenting with problems that are related to their obesity, right? And so now that we have tools, everybody wants to know about it. And part of this demand is actually being created by patients. Patients are phoning their doctor's offices asking for prescription. I don't know if you know this, a couple of years ago, we came up with what we call the 5 A's of obesity. And the first A was ask, where we were saying, oh, you have to be very, it's a sensitive topic. You got to ask for permission, ask your patients if they're willing to talk about obesity or their weight. Now patients are asking, right? I mean, now the ask has changed. Now they ask, why do you want a prescription, right? Because that's what they're here for. So this is a radical change.
I mean, I agree, but I mean, we're still dealing today with stigma and blame. I still see it. I still hear it. I mean, I was given a talk on obesity and a guy in the audience, I mean, this is mind-boggling, got up and said, have you ever seen an obese runner? That was the actual quote.
Yeah, the funny thing is actually there are. I've had patients at BMI's 40 running half marathon.
For sure.
Absolutely there is. Absolutely. But I mean, why are we still dealing with that? Like, why are physicians still not getting it? Because they're not all getting it.
Because they've never learned it, right? I mean, nobody ever learned obesity. In fact, I think we're still graduating and licensing doctors today who in their entire training, medical school, everything included, have never, ever treated anybody for obesity. I mean, they've treated a lot of people with obesity, but they've never actually managed anybody for their obesity. So we're still not teaching this to people. I mean, now I think they're starting to learn a little bit more about the science. But, just imagine giving a medical license to someone to practice medicine who has never, ever managed anyone with diabetes. I mean, you wouldn't license that person, right? Or someone who's never managed hypertension. It doesn't matter if at the end of the day you end up being...
And we have to, I mean, like the 3 pillars of Obesity Canada say, of the obesity guidelines, we help people lose weight and it will help them eat better and move more. And we have to emphasize it's the other way around. That's the right way.
Jeff, you're so right. I mean, that's one of the funny observations is that there's a lot of people who, I don't want to advocate that all you have to do is, take the injection and you'll be fine. No. But what we are actually seeing, and patients, tell you that, the minute I start taking these medications, my whole approach to eating changes, right? I mean, I look at food, I can make healthy choices, all the stuff I couldn't do, without the injection, I can now do. And as they start losing weight, a lot of them actually, go back to being physically active because now their knees are no longer hurting, their feet are better, their ankles are better, they're sleeping better because their sleep apnea got better, their mood improves, and suddenly they're better. So, I refer to this as pharmacological behavior change, right? I mean, all these behaviors the patient just couldn't do.
Well, I have a patient. I have a patient who lost weight, it was a feed forward. She felt better about herself. She applied for job promotions, got them. She started dating. And it was actually that patient encounter that was a pivotal moment for me for shifting the way I was prescribing, this class of medications. I guess I just worry, like anything else, when you're swinging the pendulum one way versus the other. I feel we're a little bit in a state right now where access to GLP-1s, and people, if they're not going to get it from me, they're going to pay $200, go online without any proper medical monitoring, advice, follow-up. And you mentioned, the art of treating obesity is to see the patient, look at them, see how swollen their legs are, take a blood pressure. And I just feel that we've transgressed in sort of pop culture and to a certain extent in general population, that obesity is something that is just weight and there's not a focus on anything else and they just want the drug, right?
Yeah, Kristen, you're so right about this. I mean, thanks to COVID, we've all gained experience doing telemedicine. And there's nothing wrong with telemedicine. I mean, I was doing telemedicine during COVID and, and it worked fine. The problem is when you create a telehealth system that's outside of the normal system, right? So it's not your family doctor that you're seeing on the screen. It's some guy who might be, I don't even know where that person may be sitting, who sees you for a couple of minutes and asks you a couple of questions and you fill a couple of forms and next thing you know, you've got the prescription in the mail, right? That kind of telemedicine is the one that we need to worry about. And it brings problems because very often these, obesity has to be embedded into medical care, right? Because as patients take these medications, especially, take, for example, you got a patient who's got hypertension, who's got diabetes, right? So they're taking medications for hypertension, they're taking medications for diabetes. Now they go online, they get a prescription, they fill the prescription, they start losing weight. Next, they're falling down because of orthostatic hypotension because nobody adjusted their hypertension meds. They're going into hypoglycemia. Nobody told them that you need to reduce your insulin. Maybe they're throwing up. So all these things happen and it's not embedded in the system, right? It's almost like you've got this obesity thing going on outside, and then for everything else, you still go to your family doctor. Right now, the family doctor doesn't even know what's happening, right? Because he's not the one in charge, or she's not in charge, right? So this parallel universe of, obesity management. I mean, don't even want to call it obesity management. I don't even know how to call it.
All right, so we're going to finish up with where are we heading in the next 10 years? What do you see?
Oh, there's two major things that are going to happen. I mean, one of them is the obesity medications. They're going to change everything, right? Because for everything that, every problem where obesity is part of the root cause, obesity management is going to be first-line treatment sooner or later, right? Your new patient with hypertension, your new patient with diabetes, your new patient with fatty liver disease, your new patient with sleep apnea, all of these guys, the first thing you think of is this guy needs to lose weight. And is going to take these medications. So that's going to change how we practice medicine. I'm going to think of heart failure, think of everything. The other part that I'm also excited about, that's AI. Artificial intelligence is finding its way into medical practice, and that is going to be the other changers. Our patients are going to be using it, doctors are going to be using it, everybody's using it. And I'm waiting for the day not too far in the distant future where my patient's avatar is talking to my avatar and they figure out what happened, what needs to be done. And then I'm just signing, whatever they ask me to sign. So that may very well be the route that we're going down. And that's going to be a very, very different type of medicine.
I mean, I think even in the next 2 years, we're going to see 3 or 4 blockbuster drugs. It's going to change our lives.
Plus, we got the medication in obesity and we've got this whole AI business going on. And that's going to change everything.
All right. Christine, I'll let you close and we'll say thank you and goodbye.
Thank you so much, Dr. Sharma. And you're coming in from Germany. So I hope you have a nice beer tonight because I'm sure it's happy hour there, not quite here yet. Thank you to our listeners and we will see you soon.
Thank you, everyone. That was great. Thank you, Arya, for coming.
Yeah, thanks for having me.